So now let's welcome our next speaker, Dr. Kotaru. Dr. Kotaru is a critical care specialist in Greenwood Village, Colorado. He graduated with honors from the University of Pittsburgh School of Medicine in 1995, having more than 28 years of diverse experience, especially critical care intensivist and pulmonary disease. Dr. Kotaru affiliates with many hospitals, including Vale Hospital, Medical Center of Aurora, South Hospital, and cooperates with many doctors and specialists in many groups, including critical care and pulmonary consultants, as well as VMC Diversified Services. So let's give him a wonderful welcome. He's going to be a great speaker. Thank you.
Hi, everybody. Thanks for your attention today. As informed, I'm Dr. Kotaru. I'm a pulmonologist. Thank you. Okay. Hi. Okay. So again, C.K. Kotaru, a pulmonologist. I've been in Colorado since 2001, and happy to give this talk today about pulmonary rehab. Next slide, please. Well, I have no conflicts of interest on this talk. Next slide, please. Okay. So you're here listening to me, so I thought I'll introduce myself and tell you who I am. I came to Colorado in 2001. I had finished my medical school in Pittsburgh, went to Cleveland for a few years, and then came here in 2001, and that is to start my fellowship in pulmonary and critical care at the University of Colorado and at National Jewish. I've had the good fortune of learning from many of the pioneers in this field, people like Dr. Thomas Petty, who I'll talk about some more later on today. I was junior faculty at the University of Colorado till 2005, and then I moved on to community-based practice in 2005. I practice in Aurora mostly. I'm at the Medical Center of Aurora, where I'm the IC director and the pulmonary director. I started the pulmonary rehab program there in 2015, and my clinical interests are lung cancer, pulmonary rehab, and ECMO. The picture next to you over there shows my other interests outside work. I love the mountains. I like to fly fish, so that's where I am when I'm not in the clinic or the hospital. So that was about me. I just want to know, maybe by show of hands, a little bit about you. Are there any providers in the room? I did? Okay. Okay, that's great. Perfect. Okay. Are there any caregivers in the room for patients, people with lung disease? No. Okay. I assume the rest are people with, okay, excellent. Okay. How about COPD? Would you be okay raising your hands if COPD is a diagnosis you have? Okay. Okay, excellent. Thank you. Okay. We'll move on. Okay. So introduction about pulmonary rehab. Next slide, please. Okay. So pulmonary rehab really is about helping people live with lung disease. As you all know, when you have lung disease, you have ups and downs every day after day. You have good days and you have bad days. On good days, you can do a lot. Bad days, you can hardly get out of bed. And the goal of rehab is really to help minimize those bad days and help improve those highs or the good days in your life. These symptoms impact life participation. So symptoms like shortness of breath and cough are the common symptoms of lung disease. But in addition to that, people with lung disease have fatigue, weakness, anxiety, sleep issues, weight issues, and all of these impact taking part in life in a normal manner. You have difficulties with activities of daily living. And all of these issues can be addressed by pulmonary rehab. So when I say we're trying to help people live with lung disease, it's not just survive, it's more thrive, to actually have a good quality of life with pulmonary rehab and lung disease. Next slide, please. Okay. A little bit about history of pulmonary rehab. Okay. Next slide, please. So Colorado actually is one of the first places where pulmonary rehab started. Many of you may know that between 1850 and 1900, Colorado became a place where people came for tuberculosis. It used to be called consumption. At that time, people were told that you need clean air, you need to rest, you need to have good food. And Colorado, with the clean mountain air, became a place where a lot of people with TB used to come. One of those persons was Dr. Charles Dennison. He actually is a pulmonologist. He had TB in about 1890, and he came to Colorado to a sanatorium. And at that time, he was taking part in this treatment plan, and he actually felt better after exercising, after walking. So what he did was he called himself an invalid at the time, and he, along with advised other people in the sanatorium, let's try exercise, let's try walking and see if that'll help your symptoms. And then he published his observations in this book, Exercise and Food for Pulmonary Invalids. This was published in 1895, and that's the first known description of pulmonary rehab in the English literature. Next slide, please. Okay. So that dapper-looking gentleman on the right there, on the left up corner there, is Dr. Thomas Petty. Thomas Petty is considered the pioneer of modern pulmonary medicine. He first published the benefit of oxygen, one of the first publications in 1968, about how oxygen can help people with lung disease. He was an avid fly fisherman. That's a picture of him with a nice trout on the Big Hole in Montana. He has over 800 publications to his name. Next slide, please. In 1969, he first published an article in the American Journal of Medicine, and that was a comprehensive care program for chronic airway obstruction. Even at that time, it was not just about exercise, but it's a comprehensive care program for people with lung disease. And he published that 94 out of 124 patients in this rehab program had better tolerance to effort, reduced number of days of hospitalization, and earlier return to work. His model was called the Petty's model, and that became the basis of pulmonary rehab programs in many places across the country. In 1974, the American College of Chest Physicians used his model to develop a statement for how pulmonary rehab should be set up. And in 1980, the American Thoracic Society followed suit as well. So if you could say that pulmonary rehab as we know it today started off in Denver, Colorado. So what is pulmonary rehab? Next slide, please. It's a comprehensive intervention. It is not just one intervention. It is a comprehensive intervention. It is meant to improve the physical and psychological condition of people with chronic respiratory disease. It is meant to promote long-term adherence to health-enhancing behaviors. Next slide, please. The rehab program is individually tailored, so not everybody gets the same plan of care or exercise. It is designed to optimize each individual's physical performance, social performance, and maintain autonomy. Next slide, please. This is called the spiral of disability in patients, people with lung disease. When you have moderate or even mild respiratory impairment, you develop shortness of breath with exertion. That leads to abstaining from exercise. When that happens, your body becomes deconditioned, gets out of shape. And then you start having symptoms even with less exercise, mild exertion. That leads to further abstinence from exercise. That leads to further deconditioning. Then you start having difficulties with daily living activities. So this is a spiral of disability that happens with lung disease. And what we are trying to do with pulmonary rehab is to break this cycle. Next slide, please. Again, the aims of pulmonary rehab are to increase exercise tolerance, increase muscle strength and endurance, reduce shortness of breath, and reverse deconditioning. Next slide, please. But it's not all about exercise. It's also about the whole the medical condition, what we're trying to do for the person. We want to increase the knowledge of a lung condition and treatments. If you have COPD, we want to explain what COPD is, how you can manage it, what the treatments are, what inhalers do. Promote self-management and coping strategies. So if somebody gets short of breath going to the grocery store, maybe taking 2 puffs of albuterol beforehand is a good idea. So we kind of talk to them about what their limitations are in their life and try to explain how to self-manage their symptoms. We talk about coping strategies. We talk about how we can improve your health-related quality of life. We increase confidence in ability to exercise. This is very important. It's very difficult to exercise when you're worried about can you breathe okay or not. So doing this in a controlled setting with the professionals who do this all the time gives you the confidence to be able to exercise and do okay. We want to increase independence and autonomy in daily life. And we want to promote long-term commitment to exercise. Next slide, please. Okay. Who is it for? It's most commonly used for COPD. That pie chart on the right shows you that between emphysema and chronic bronchitis, which falls under COPD, about 75% or 3/4 of pulmonary rehab patients have these conditions. It doesn't mean they're the only conditions that you qualify for pulmonary rehab. Asthma, pulmonary fibrosis, restrictive lung disease, lung cancer, and other categories like post-COVID syndromes, lung transplantation, pulmonary hypertension, all those fall in the other category. So this is meant for a whole variety of conditions, not just for COPD. Next slide, please. Okay. So how does it work? It falls on the physician, the provider, to identify patients who are eligible for pulmonary rehab, but certainly patients and their families can advocate for themselves and talk to us about, hey, I want to get better in exercise. What can I do? You're required to have a diagnosis of a chronic, stable respiratory disorder with disabling symptoms and impaired patient function. Almost always you get a pulmonary function test. That's a breathing test that is meant to assess your lung capacity. And you need to have a limitation of less than 65% on some of the measurements to be able to qualify for pulmonary rehab. Now that is changing all the time, and sometimes we can even get patients qualified without these parameters. So it's important to have the conversation with your physician about, I'm limited even though my pulmonary function is okay, can I still qualify for it? And we are often able to do that for many patients. There should be an expectation of measurable improvement in a reasonable and predictable amount of time. That basically means that if you have, like, let's say, a chronic heart condition that is causing you to have more symptoms, taking part in pulmonary rehab at that time may not be the best thing. But if you have, if the heart condition is treated, then you can certainly take part in pulmonary rehab. Patients must be able, motivated, and willing to participate in the rehab program. The essential components of pulmonary rehab, at least at this point, most of these programs are based in a pulmonary rehab center. There are very few places that are doing tele-rehab or community-based pulmonary rehab. So typically what happens is when you're identified to have a condition that qualifies for pulmonary rehab, a referral is sent by the provider to the rehab center. Typically, at that time, the person directing your intake is going to have you go through a walking test, a 6-minute walking test. That is basically to get an assessment of what is your functional capacity, what's your oxygen level when you walk. They also give you a series of questionnaires about your quality of life, your shortness of breath, what are your symptoms that are limiting you. They assess your nutrition. And then they individualize a program that is prescribed for you. Now, next slide, please. I'm going to skip this slide. Just go to the next slide, please. Okay. So the goals of rehab are to reverse the deconditioning and cardiovascular dysfunction and it's individualized for the person. It includes exercise, education, behavior management, and improvement of social and psychological function. Next slide, please. Typically, the program is up 8 to 12 weeks in duration, usually twice a day. Each session is about 45 to 60 minutes. And it's individualized to, based on your needs. That may include upper body and lower body muscle training, aerobic exercise, and respiratory muscle training. They also give you homework. They also tell you between your exercise sessions, when you go home, you should try to do some more things at home. And this comes from the Stay Active guidelines that CDC puts out. And there is clear benefit in exercise in how long people live. And at least 150 minutes of exercise per week comes to about half an hour for 5 days a week, makes people live longer. So the goal is to improve people's exercise programs in their daily life long term. Next slide, please. But along with exercise, there's also education that goes on with pulmonary rehab. So most often we talk about oxygen use. We talk about why you use oxygen, how it helps your shortness of breath, how it can help you exercise more, what blood lactate is. Lactate is something that the muscles produce when they don't have enough oxygen. That makes your muscles fatigued. So having oxygen can help with that. So we talk about what oxygen does for that. We talk about how oxygen is needed for your neurologic and psychological performance. We talk about how oxygen allows better blood flow through your lungs. Next slide, please. Okay. There are many questions with oxygen that we get asked all the time, and when we talk to our respiratory therapists, we kind of discuss these kinds of things. Why am I being prescribed oxygen? Okay, what is a low oxygen for me? One of the more common questions is, will I become dependent or addicted to oxygen if I start using it? The answer is no, but we get guess all the time. So these are the things that we try to address with oxygen during pulmonary rehab. Next slide, please. We talk about tobacco cessation. Clearly, tobacco kills, and every session, if it is appropriate, we bring up tobacco cessation and ask. We advise about what options there are offered to help with cravings, and we assist them in helping quit. At Aurora, we have 2 tobacco treatment specialists who take part in the rehab program as well. So they're really available to talk to patients about this part of it also. They talk about pharmacotherapy, meaning they talk about things like Chantix, nicotine replacement, how that will help you with the cravings when you try to quit smoking. We talk about lung cancer screening. We know that lung cancer is the most deadly cancer in the US. And if you have a smoking history of 20 pack years, which is 1 pack a day for 20 years, you qualify for lung cancer screening. This is a patient of mine who got screened for lung cancer. There is about a 1 centimeter nodule there, the green arrow. Turned out to be a early lung cancer. She got that radiated, and she's cancer-free 4 years later. And this happened as we talk about screening in patients who smoke at pulmonary rehab. We talk about airway secretion clearance. This is a big symptom that people with chronic lung disease have, whether it's asthma, whether it's COPD, or cystic fibrosis. How to keep your airways clear of mucus. Mucus causes more airway resistance. It increases the work of breathing. It helps not enough oxygen get into your blood. So really, clearing mucus is very important in people with chronic lung disease. So they talk about postural drainage. They talk about vibration vests. They talk about incentive spirometry and other devices that help you with mucus clearance. We talk about breathing exercise. We talk about pursed lip breathing. I think most people know how to do this, but we kind of teach them about how to breathe in and how to breathe out, and how this pattern of breathing with chronic lung disease can help with your oxygen levels, your work of breathing, we talk about infection prevention. This is key in how to prevent exacerbations, how to prevent your lung disease from getting worse. So The infections that we worry about for lungs are the flu, pneumonia, COVID-19, RSV. So it's important to make sure you get these vaccines. And we talked, when the time comes, we talk to them about these vaccines, about getting them updated. Okay. It's not just about lungs. We also talk about other conditions. We know that sleep apnea and chronic lung disease go hand in hand. So we often talk about are they having difficulty with sleeping. And then they can do sleep questionnaires, and they call the provider and say, it looks like your patient may have a sleep apnea condition, and then the provider can do a sleep study to diagnose that. We talk about emotional, psychological needs of a patient, and sometimes we do refer them to psychotherapy or medicines to help with that. Sometimes we also talk about advanced care planning. Okay. So now I'll switch gears and talk mostly about pulmonary rehab in COPD. COPD is chronic obstructive pulmonary disease. In that cartoon there, it shows how on the right, when you have COPD, your airways are narrowed, you have more mucus production, and the air sacs of the alveoli are enlarged and abnormal. Next slide, please. So in patients with COPD are physically less active. They have loss of especially lower limb muscle mass and muscle function. And about 40% of the patients with COPD do not achieve the recommended physical activity. So that's why COPD has been a condition where pulmonary rehab has been, I guess, initially started. Next slide, please. As COPD progresses, patients become more and more sedentary. That leads to them to have more muscular and cardiovascular deconditioning. And this disability leads to social isolation and depression. Next slide, please. This is a table that was published in 2008 that looked at the prevalence of depression in people with many different conditions. So how many people with COPD have depression? On the first column there, you have 40.4%. So if you look at cancer down there, that's 26%. So more people with COPD have depression than patients with cancer. And it really comes down to their physical ability, the ability of their the activities of daily living, how they are so limited. And it's really very important for us to work on those aspects of it. And we'll talk about how rehab helps with this down the line. But it's very important to recognize that depression is very, very common in patients with COPD. The next slides I'm going to show come from the Cochrane Library. For physicians or providers in the room, you probably know that this is considered the place to go when, to look for guidelines when there's potential a lack of adequate studies. Next slide, please. And pulmonary rehab has been clearly shown to increase patients' ability to walk or exercise. So as I said before, we do a 6-minute walk test at the start of the program. And at the end of the program, we repeat the test. And on average, a person is able to walk 44 meters or 48 yards more at the end of the program. That's half a football field's length. So it's a very significant amount. There's another test called the incremental shuttle walk test that is done mostly abroad. And that also showed improvement in their walk distance, 43 yards, so pretty significant. There's been clear benefit in improvement in shortness of breath. We give people questionnaires. One of them is called the Chronic Respiratory Disease Dyspnea Score. And they rate their own shortness of breath with different activities before and after. And there's clear improvement in multiple domains when it comes to shortness of breath. Same thing with quality of life. There's something called the St. George's Respiratory Questionnaire that looks at the quality of life in patients with lung disease. And there is significant improvement in multiple domains in terms of how they can enjoy life at the end of rehab compared to before they started. Slide, please. So they made this remarkable statement at the end of the review of these articles. What they basically said was, it is our opinion that additional RCTs comparing pulmonary rehab and conventional care in COPD are not warranted. essentially saying that the science is settled. We know that pulmonary rehab works. So there's no need to do any more studies to say, does it work or not? What we should focus on is to figure out why does it work, what kind of exercise makes it better, how long are the benefits lasting, and those kinds of things. But at this point, it's very clear that pulmonary rehab clearly works for patients with COPD. Next slide, please. This is something that is more recent and has not taken up as much attention, but it is very important for us to know. When somebody has an acute exacerbation, meaning that their COPD has flared up, and they end up in the hospital, if they start a rehab program within 30 days, they have a much lesser chance of getting back into the hospital over the next 25 weeks. That number, the odds ratio, is 0.22. What that means is you have 80% less chance of ending up in the hospital if you start a rehab program after being hospitalized for COPD. And the NNT stands for number needed to treat, meaning if you treat 4 patients with pulmonary rehab after they're hospitalized, one of them is not going to end up in the hospital. So that's a very, very significant number. It also decreases mortality, chance of dying. That odds ratio is 0.28. That goes on over a matter of about 2 years. Again, a very significant number. So pulmonary rehab after exacerbation is able to prevent further exacerbation and also prevent death in the next 2 years. Go back, please. It also improves objective exercise assessment. We talked about the walk distance. It improves quality of life. And more importantly than everything else, there is no significant adverse effects, meaning it is okay for you to exercise after you have an exacerbation. You should not feel limited, obviously depending on what your doctor tells you. But when you go to rehab program after exacerbation, you are not having any adverse effects, meaning it's not going to put you back in the hospital. It's going to prevent that. Next slide, please. So the benefits, as we talked about, are there is improved exercise capacity. It improves health-related quality of life, reduced hospitalization and length of stay, reduced mortality, reduced anxiety, depression associated with COPD. And the benefits probably extend well beyond the period of rehab. Even the rehab program is about 8 to 12 weeks. The benefits extend long beyond that, especially if the exercise training is maintained at home. Next slide, please. Just a brief slide about post-COVID syndromes. This was published in 2020. And basically, we know that there is something called long COVID. There's a lot of unknown about what this is or what the mechanism is. But a lot of patients with COVID-19, especially if they had a very severe illness, continue to have symptoms after their acute illness has already happened. And part of the symptoms that they have with this are shortness of breath, oxygen need, and cough. And pulmonary rehab is being studied in these conditions, in this condition, and there is some early data that this could be beneficial. This led CMS, Medicare, to add COVID-19, post-COVID-19 respiratory disability as a reason to start pulmonary rehab. Next slide, please. So what if you don't qualify? Meaning, what if you don't have the right diagnosis that we talked about, or if you have other conditions that limit activity, such as cardiac disease, neurologic disease, arthritis, or physically too limited? I think it's important to talk to your doctor. I mean, I think there always are other options: physical therapy, occupational therapy, and other exercise programs are available that may not be pulmonary rehab. Next slide, please. Okay. This is some of the feedback that we often hear when somebody complete their rehab program. Wish it was longer. Got my life back. I'm in control. I'm much more confident. I achieved goals and more. My illness no longer controls me, controls my life. Feels better about myself. So it's really positive comments about pulmonary rehab. Next slide, please. Okay. I'll stop there. Thank you for your attention. Thank you to the ALA for supporting these initiatives, and I'll take any questions.
Can I ask real quick?
Yes. Yeah.
Will you raise your hand if you've been through pulmonary rehab?
Awesome. That's perfect.
Look around and talk to them. Yeah.
Yeah, that's great.
So any questions?
So maybe you will understand me, Gus.
Yes.
So my question to you is like I would like to do the rehab with my husband, and they said he cannot come. He doesn't have, but I would like him to support me
Yeah.
to come.
Yeah,
You know,
we used to do that. But what happened is that, well, COVID was one thing where we had to limit people, we had to spread people out. But the demand is so high for the rehab programs these days. The access is a big issue. So wait periods are long. So we used to allow family members exercise with their loved ones with lung disease in a rehab program. But right now, I think access is an issue. So sorry. Yeah.
Yes. I was wondering, in the greater metro area, how many of these pulmonary rehab places are there for people to go to? In other words, for all the people who need it all over the area, how many different places are there?
Yeah, definitely not enough. So I think in Colorado, when I last counted, there were about 12 programs. Maybe there will be a couple more now, but yeah, it's very, very limited access. I think in Denver, there are about 8 programs. And yeah, and I think, yeah. Is there a particular location that you're interested in? I can see if there is something there. What location are you interested in? Oh, okay, I see, got it. Okay, yeah, okay, yeah, okay. Yeah. No, it is a problem, and I think we always advocate for it. We write to our Congress people about it. The efforts that ALA does to increase access is very important. But please write to your congressman and our woman and say, hey, we need more pulmonary rehab programs here because we don't have access.
Hi, I'm a therapist in a pulmonary rehab right now, and I do a lot of education, and I can get my patients through the education portion of pulmonary rehab, but when it comes to exercise, they seem to fall out. Do you have any tricks of the trade to try to keep the patients in the program for the full duration of their insurance prescription?
Are they falling out because of symptoms, or is there a particular reason? I think it's varied for each person.
They seem to be falling out because they don't feel that the exercise is going to benefit them. They basically just want the education and not the exercise. Is there a way that we can advocate to them that the exercise is more important than actually the education, just to get them moving?
Yeah.
I mean, we try our best, but we just can't get them to stay motivated to keep coming.
Sure. No, I think it's a challenge. I think it depends upon the individual's motivations and why they're coming, and continued education about why rehab is going to help them is key. I don't know if I have any more tricks beyond that.
I will talk to Amy,
Yeah,
to Linda, or Wanda.
there you go. Yeah. Yes, go ahead. Well, you raise a good point. I mean, having advocates, people who have been through the program, maybe come and talk to them about it, maybe a good way to motivate them.
So my question also has to do somewhat with access and maintenance of pulmonary rehab. I have been in pulmonary rehab for almost 12 years now as a double lung transplant patient. But I know one of the hardest things for me when I started was that being as young as I am on Medicare. Now with Medicare, which I'm assuming, which I shouldn't, but most of the patients here are on Medicare. When it comes to pulmonary rehab, there's a lifetime of visits, which are 36 for your lifetime.
I think it's 72.
And if they can make an exception, it can be 72.
Yeah.
Now, some of these programs are it's so hard to get into them,
Yeah.
yet alone try to get a part of the maintenance program. Yeah. Now, coming from an advocacy aspect, Do you know if there's any type of movement to where they're trying to get this to where you can get more, like say just regular physical therapy or occupational therapy? How many times do doctors write a script for that? And then once it's up, they go, well, we'll just write another one. You can't do that for pulmonary rehab. Do you know if there's anything that they're doing to where they can make it somewhat kind of like that so it's easier and it's more accessible for patients who want to do this? And I think that's one reason why some people drop out is because, well, I can't afford it or I don't have any more visits to do that.
Yeah, no, I think you raised a very valid point, and there have been changes to requirements for pulmonary rehab. There used to be a requirement that you need to have a physician initial visit, and that went away. That's because of advocacy saying that that's delaying patients from coming into rehab program. I agree with you. I think the 72 with an exception limit should go away. But it also means that we need many more centers to be able to absorb all the workload that's going to be there. And I think there is advocacy to increase reimbursement for pulmonary rehab to actually have more centers available. And we talked about, there are studies about telehealth, there are studies about other ways to do this. But again, that's still in very infancy. But there is a very, very valid point, and there is advocacy going on. When I talk to somebody about in the Congress about this, I bring this up for sure that we need more of this.
And if I can say something to help lobby for that with our elected officials, they want to hear from you.
Yeah.
They want to hear from patients. So if there's some way we could get you involved in that kind of advocacy, we'd love to do that. And Nick over here is our wonderful director of advocacy.
Thanks, Alan. I just would reiterate, I hear time and again from legislators, whether it's the federal level, state and local levels, we're always asking for policy change to have these lasting effects on the patients that we're serving, right? They want to hear those personal stories. They want to hear how the metro area's air quality issues are affecting folks with chronic lung disease. They want to hear how your challenges of accessing the federal agencies. I've heard from several people just today about access to oxygen. That's a huge issue, right? They want to know how your experiences living here in Colorado are playing out in the ways that you're interacting with the federal agencies or the state agencies. And so I'm here to help be that conduit. I would love to set up meetings, help advocate for those issues. I frankly would love to learn more about the ways that chronic lung disease is affecting your life here in Colorado and the things that we can do at the policy level to make your lives better. That's our mission. That's why we're here. That's why I do what I do. And it's really powerful to hear those stories today. So thank you all for being here.
I would also like to echo everyone's sentiments in here with regards to the importance of pulmonary rehab, the fact that you all are here and the wonderful success stories that we're hearing. This is a needed service. We need to advocate for it. Thank you, Doctor, for all that you're doing and all the pioneers that have helped. I'm going to come at this a slightly different direction, only because it's not a replacement for all those things, but it's an additional piece of the puzzle. I'm a physical therapist. I do home care. I go to people's homes. Probably 80 to 90% of the people that I treat on a daily basis have breathing issues, breathing problems. 50% of them are on oxygen. I'm sharing that with you. So, for example, for the patients that you talk about that maybe drop out, maybe it's transportation issues, maybe it's family support. It could be a variety of other things. There are people that have a struggle just getting out of bed to get to you. There are also services where you can go into the home. Or someone like myself, home health agencies can go into the home, and we can start from that direction, advocate for getting the process going from the home environment, support from families. The exercise program initially may not be on a treadmill, but it may simply be walking down the hallway or walking down the steps or walking in the backyard. And if we can get that going, we can maybe challenge those folks back to pulmonary rehab or be that bridge for those folks who aren't able to. So do know that there are also those services out there. You can talk to your physicians, primary cares about that, and those may be alternative to some of the problems that you're running into.
That's an excellent point.
My family's really after me because I've had heart surgery. I had a valve put in, a complete valve, total. And if it wouldn't be for this pulmonary thing, I don't think I'd be exercising like I am right now. And it's 36 weeks. Okay, I'm going to be there for 36 weeks. And it's got me back into the thing of where I was before, because I used to walk a bunch. I used to walk an hour every morning. And it was every week, at least 3 times a week, 12 miles within that week. I think you need to go ahead and just be more active and try to help a person that isn't to get into that mindset. Coming here, I'm finally out of into myself, and let's go somewhere else. I did that this few weeks ago. I went and worked with COMOM for 5 days, and that is a free dental for anybody. No cost, 100 to 250 doctors, hygienists, oral surgeons, everybody in there. And we don't get enough of our public there. We only had 1,000, maybe 1,200 there. We should be able to, in our community and in our areas, get groups and people to come, so we have 3,000 or 4,000 people getting taken care of free with this program, and nobody's doing anything about it.
Okay.
You can understand me.
I can hear you, yes.
I just want to say, like, the team from Colorado Springs, Laurie, everybody, they changed my life. And as a Canadian, and I'm from Canada, my gosh, I know people, they could go to the program. They don't want to drive their car to go. I'm like, oh my gosh, Medicare pay for that. So to me, there's no reason not to get up and go,
Yeah.
when you get accepted to something like that.
Appreciate your comment. Yeah. Yes. Uh-huh. Yes. Yes.
Let's give Dr. Kotaru a big hand. Thank you very much.
Thank you, guys. Okay.
Thank you, Doctor. Also, Health One has been such an amazing supporter of this particular symposium today, and sending over a very busy doctor was really fantastic gift to us, really. So thank you for being here today. We're very grateful for you. Thank you so much. A pleasure to meet you. Thank you.